We're so excited to welcome you here to our session. I'm really pleased to be here with my chavruta, Racheli Tavis, and two amazing physical therapists, Riva Prel and Rivki Chudnoff. My name is Stacy Goldman, and I live in Philadelphia, where I am the Yoetzet Halacha, and also the Yoetzet Halacha for Las Vegas. I also teach Tanakh at Kohelet Yeshiva High School in Philadelphia.
Hi, I'm Rivki Chudnoff. I'm a pelvic health physical therapist. I've been a PT for over 20 years. In addition to working in my practice in Teaneck, New Jersey, where I see women from all over the tri-state area, Muncie, New Jersey, and New York, I treat women primarily with pelvic pain, urinary and fecal incontinence, pregnancy and postpartum issues. And I'm also on faculty at Herman and Wallace Pelvic Rehabilitation Institute.
Hi, my name is Racheli Tavis, and I live in Washington Heights, New York City, where I serve as the Rebbitzin and Yoetzet Halacha of Mount Sinai Jewish Center. And I also teach science and Judaic studies at Bayeno Yeshiva High School for girls in Teaneck, New Jersey, as well as I teach Judaic studies at Stern College for women.
Hi, good evening. My name is Riva Prel. I'm a pelvic floor physical therapist. I have a private practice in Manhattan called Revitalize Physical Therapy. I'm board certified by the American Physical Therapy Association as a women's health specialist. I'm also board certified in biofeedback for pelvic muscle dysfunction, and I'm a certified lymphedema therapist. I love opportunities like this to lecture and share information with both the medical and lay communities. Also exciting news, I recently hired a male pelvic floor therapist who can help treat individuals who prefer seeing male pelvic floor therapists, a male pelvic floor therapist. And finally, I recently released a book, The Inside Story, The Jewish Woman's Guide to Lifelong Pelvic Health, which is available on Amazon. Tonight, we would like to share several case studies that show the convergence of pelvic floor therapy with Yoetzet. Our professions love each other. There's a beautiful relationship between pelvic floor therapists and Yoetzet, and we love helping women and collaborating on their behalf. And we wanted to encourage you that even if your pelvic floor therapist isn't a religious Jew, we encourage you to speak to your Yoetzet about any concerns that you may have over the course of treatment, and they would be happy to speak to your pelvic floor therapist to help address any issues that arise and make sure that you're fully comfortable with every aspect of treatment. Furthermore, we wanted to point out that we will be monitoring and trying to answer any questions that arise in the chat throughout the session. But in case we miss anything, our contact information will all be available to you at the end of the presentation, and we would love to answer any questions privately offline as well. So the case studies that we would like to address, I'm going to be presenting with Yoetzet Rebbitzin Racheli Tavis, and the question that we'll be addressing is one of when there is blood that may arise either on dilators or when patients are doing homework, or when there may be blood that is noticed on the glove of the physical therapist in the middle of a session. But before we even get into the question, first it's important to understand what the pelvic floor is. So I have here my little pelvic model, and as you can see, this is a pelvis. And all of these red structures here are muscles. And the pelvic floor muscles span front to back from the pubic bone to the tailbone or the coccyx and side to side. And they serve three primary functions. The first function is in maintaining bowel and bladder continence. The second function is in assisting with supporting the organs in the pelvic floor, which front to back are the bladder, the uterus, and the rectum. And the third function is sexual functioning. So when it comes to these muscles, just like any other muscle group in the body, the muscles, we want them to ideally be at a normal, happy resting tone. Sometimes, for whatever reason, the muscles may get tight or they may be overactive or in a state of spasm, versus the opposite end of the spectrum is the muscles may get overstretched and weakened, and that would be underactivity of the pelvic floor muscles. So when there is any issue with the pelvic floor muscles, it can manifest as bowel, bladder, and or sexual dysfunction. And it's our job as PTs to determine what's the problem with the muscles. Are the muscles too tight and that's what's causing problems? Or the muscles too weak and that's what is causing problems? When the muscles are too tight, then a patient stands to benefit from a stretching, down training, releasing program. And in that case, a pelvic floor therapist will likely encourage their patient to use tools, either dilators, which are plastic, silicone, or glass devices that can be inserted vaginally to help stretch the muscles. And as you see, they come in lots of different sizes. They can be itty bitty, very small all the way on the right. And then as you see on the left, they keep getting larger and larger. And we want to help. It's a form of graded exposure therapy. We want to teach the patient how to be able to tolerate increasing sized devices into their pelvic floor so that ultimately, functionally, they'll be able to participate in intercourse pain-free or be able to tolerate a gynecological speculum examination pain-free. So these are the homework tools that we encourage our patients to use on occasion when there's overactivity and tightness versus underactivity and weakness. And when that's the case, then a patient would stand to benefit from uptraining or strengthening, also known as Kegel exercises. If there is overactivity, do not do Kegel exercises. That is one of the big misconceptions. Sometimes people think if I have a problem with my pelvic floor, I should be doing Kegels. Not necessarily, only if there's underactivity or weakness. However, if there's overactivity, then these dilators are more likely to be your best friend as opposed to Kegel exercises. Now, sometimes, on rare occasions, I've had patients come in and report that after using their dilator for homework, they noticed a little bit of blood on the dilator. Or sometimes when I finish doing internal work on a patient and I remove my hand, we do internal vaginal work in pelvic floor therapy, then there may be a little blood on the glove. So, Racheli, if that is the case, what does one do halachically?
Okay, so the laws of Nida, and I'm going to pull up my slides so that you can see that. So the laws of Nida are found in Sefer Vayikra. And one of the fundamental verses on the laws of Nida are from Vayikra, Leviticus 15, verse 19, where it says, V'isha kiti yazava, dam yazava bivsara, shiv'as yamim tehei b'nidusa, v'chala hanogeya bayitami ad ha'arev. That when a woman has a flow, her discharge being blood from her body, and the highlighted words are going to be key here, she's now in a nida status for 7 days. She's tamea, and anyone who touches her is tameh as well. Now, the word bivsara, which is translated as in her flesh, teaches us an important topic known as hargasha, which is a sensation prior to flow. Hargasha literally means a feeling. So meaning that a woman can be in nida when the blood is still inside her and has not yet come out of the body. If there is this feeling or sensation. And blood of any amount found with a hargasha does render a woman a nida. So now many, not all, but many women don't have this feeling of hargasha on a regular monthly basis. But in certain circumstances, when a woman experiences other strong sensation in the genital area, there is concern that she may have had, in fact, had a hargasha, but overlooked it or mistakenly attributed it to another sensation. And so one of these circumstances include blood that is found after an internal examination, such as a badika, which is why we often tell women not to do a badika unless it is a required time, like it's during the Shiva Nikiyim, which are the 7 days before mikvah, or it's during the time of her veset, which is the time that she anticipates her period coming. Or, like Dr. Prale just said, inserting another object like a tampon, or in this case, a dilator. So the key idea here is to know that if the blood is found internally, whether on a badika cloth or another tool, let's say a dilator or a medical professional's gloves from doing an exam, then that would also render a woman a nida since the blood was found internally. But it isn't clear cut if blood found on a dilator automatically makes a woman a nida, because there's another concept known as damaka, blood found from a wound. Now, the Gemara says in Talmud Bavli, Maseches Nida, Daf Tezayin Amud Aleph, Titania Hayroa Dam Machmas Maka, right? A woman who sees blood that is due to a wound, afilu b'sochi nidasa tahora, even if it's during the time that she is a nida tahora, she's tahora from the blood that she found that came from the Makkah. Divrei Rebbe Shimon ben Gamliel, the Rebbe Omer im Yish Leveset Chosheshes Levesta. And Rabbi Yehuda Hanasi says, but if she has a fixed menstrual cycle and she sees blood on the time that she expects her period to be, then in that case, we would actually have to be concerned that the blood found was from her menstrual cycle and therefore would render her a nida. So what we see from here is this concept of if blood comes from a makkah, from a wound that's not in the uterus or that's non-uterine blood, then that would be a case where actually that doesn't make a woman a nida. Not all blood renders a woman a nida. What makes a woman nida is uterine blood. So if the blood is not from the uterus, then it doesn't render a woman a nida. So if a woman found blood, and even if she found it internally, but if the blood was, let's say, vaginal or cervical, then she wouldn't be a nida from that case because it's not uterine. But it's important to mention that we need to be really like 100% certain and really confident that this is a non-uterine blood, that there is in fact a wound. You can't just say like, oh, maybe I have some like vaginal bleeding. Like if there's no reason to suspect that, then we can't just rely on that. And so to establish and to determine that there is a makkah, in order to rely on this concept of damaka, we often do need a professional and medical knowledge and confirmation of the source of that blood. Now, in addition, what the ends of the last statement in the Gemara of Rabbi Yehuda Hanasi is that the Gemara states that blood from the wound can only be assumed as much if it was not during the time that she expects her period. So if a woman is expecting her period, then she wouldn't necessarily be able to say for certain that this was damaka and not damnida. So then maybe in that type of situation, where, she is experiencing blood, but it's around the time of her period, then we may have to say she's a nida. But in a situation where the dilation itself might have caused bleeding, either vaginal or cervical, or a woman was doing it, her exercise at home, and maybe that caused an injury to herself. And so in that case, blood found would not render her a nida. And just the final thing I want to say about this case, but really what's is true for all the future cases, is that when it comes to a medical professional, when it comes to our pelvic floor therapists, we trust the medical professional, especially if they are observant Jews, which can be very helpful to patients who are practicing the laws of nida, and in situations where we need to rely on the medical professional opinion and confirmation to say what's the source of the blood, and for the therapist to say this is not uterine bleeding, so then we can trust the therapist. And it also is on the flip that if an observant therapist or doctor says they can't confirm that the bleeding is non-uterine, then we trust them all the same. And then in such a case, it would render the woman a nida.
Okay, are we ready for case number 2? Thank you so much, Racheli and Riva. That was really great. I want to just preface by saying that the case studies that we're talking about are not based on any one couple, but a composite of cases that are commonly brought up in pelvic health settings and in halacha. Yoetzet, Stacy Goldman, and I will be discussing a case of a 23-year-old married woman who's been married a few days. And she, starts frantically calling the office of a pelvic floor therapist because she's worried that she's been married a couple of days and they haven't been able to have intercourse yet. They've been trying, and their attempts they've not been able to have penetration. And she's concerned that it's not normal, that this isn't working right away. Oftentimes, and we get these kinds of calls. And it's important to know that there is a normal learning curve, and an overwhelming number of couples do take time in order to be able to have penetration. It often does not happen the first night, and that's normal. And it's important that couples know that it's a learning process and they could be working at their own pace. And that's comfortable for both of them sexually and emotionally as they develop their relationship with each other. The only time that it would be of concern, the only time that there would be a red flag like, oh, this isn't normal, is if there's pain involved. So neither partner should be in any pain when they're attempting intercourse. And if that is the case, that they are having, so the first question I would say is there any pain? Are you experiencing any pain with these attempts at intercourse? And if that is the case, then we want to make that should not be ignored. We want to make sure that that they're not pushing through that. The statistics are like 1 in 7 women experience pelvic pain at some point in their life. So even though, like I say to my patients all the time, people don't in our community don't generally talk about their sex lives over the water cooler. But it is so much more common than people know. And it's common, but not normal. So they shouldn't be pushing through it. They shouldn't be saying, oh, it's supposed to be this way. They should, go see a doctor, go see a pelvic floor therapist, to make sure that, that they can get the support that they need. Another red flag would tell me they should seek medical help sooner than later would be if this is causing an undue amount of stress and anxiety for the couple, and their relationship starts to become very stressful because they're stressed out about it. So that might be helpful for them to come see a pelvic floor PT who might be really helpful in helping this colleague go over her anatomy, positioning, being able to put her at ease. This also might be something that if there is a colleague who is particularly anxious about, her getting married and starting a sexual relationship, then a quick visit to a pelvic floor therapist to just go over her anatomy, feeling like she knows where her vulva is and knows where her vaginal opening is. And also to be examined definitely all women should have a gynecological exam by a physician before they become sexually active. So if they are becoming sexually active for the first time before the wedding, they need to be seeing a physician to make sure that there are no medical issues. You don't want to be finding out about things, the day after the wedding. If these are issues that could be quickly rectified, before the wedding, that is even better. So we want to make sure that they're getting the proper medical support. So in this case, this woman is she's worried that she's going to be getting her period before they have intercourse. So let's assume that she doesn't have any pain in the first case, and she is just concerned that she's going to get her period before they have intercourse. And she heard from her friend that they can't be alone together if she gets her period and if they haven't had sex yet. And this is making her more stressed about getting it done and being able to have full penetration. It's putting a lot of undue pressure on them. So the question to Yoetzet Stacey would be, do they really need to be having sex before she gets her period in this kind of situation of a newly married couple who have not been sexually active prior to marriage, let's assume?
Okay, great. So I just want to give there was a question about that Racheli answered about Yoetzet and our expertise in pelvic floor therapy. We are not pelvic floor therapists, but we're very fortunate that in addition to our halachic curriculum, we have a full medical curriculum where experts like Riva and Rivki come and speak to the Yoetzet to share with us some of their expertise, and so that we know when and how to reference to a pelvic floor therapist. So back to our case. Before we discuss the halacha, I would like to stress again, in the same way Rivki did, how normal this is for newly married couples. They are not alone. Many couples experience this in the early days of their marriage. If a woman had called me first as a Yoetzet before reaching out to the PT, and there was no pain or discomfort, as Rivki said, in their attempts to consummate, I would recommend that they wait till the next month to figure it out. It's totally normal. And I'm available to discuss different positions or other techniques that could make things easier for the next time. If, however, there was pain or discomfort, then I would immediately refer them to a qualified professional. Okay, in terms of the halachic issues in this situation, there's a great reason. It's a great reason to make sure that every new couple has a Rav and or a Yoetzet that they both respect and that they can both listen to and trust. The first issue is if she gets her period and becomes a nida before they consummate the marriage. So I'm going to go to my slides now. So the Gemara, interestingly enough, in the context of a velut, of mourning, mourning, where sexual activity is not permitted, when a couple, God forbid, one of their parents were to die around the time of the wedding. So it tells us that the woman should sleep with the woman and the men should sleep with the men, that they can't sleep together. And it does mention this case of a couple where before they're able to consummate the marriage, but they're already married, that the woman does get her period, in which case, again, the men sleep with the men and the woman sleeps with the woman. So it looks like we have a not so good situation with this young couple that were not able to consummate the marriage. This is then brought down in the Shulchan Aruch, where the Shulchan Aruch says the same thing, basically quoting the Gemara, that Hu Yashan Bein HaAnashim, he sleeps with the men, He Yashena Bein HaNashim, and she should sleep with the women. The Ramah, however, Rav Moshe Isserlis, who's the Ashkenazi gloss on Rav Yosef Kairo's Sephardi halachot of the Shulchan Aruch, he also already offers us a slight open door for how we can deal with this in a more lenient way. And he says that there are those who say that if she was tahora when they married, so we're not talking about what we call a chupat nida, where the woman has not been able to get to the mikveh before the wedding. That's a different set of halachot. So this is a case where she did get to the mikveh, they were married under the chuppah, and then that evening before they were able to consummate, she saw that she got her period, or pirsa nida achar kach. After the marriage, she got her period. Eino tzarich shimur od, that they do not need any supervision, unlike what the Shulchan Aruch said above. But then he finishes with v'hamachmir, those who are strict, meaning those who would still observe the separation of the men with the men and the women with the women, tavo alav bracha. That's what those three letters mean. A blessing should come upon them. So he's saying to be more strict. Now, in terms of how this developed further to today, this is Rav Ovadia Yosef. He is the foremost posek in the Sephardi world and accepted by most Ashkenazim as well. This is by no means the only opinion out there. There are rabbis who will be more strict, but in our worlds, this is the vast majority of rabbis do paskin this way. So everyone should speak to their own local Orthodox rabbi. So he says that a chatan shenisa liv'ol bi'ilat mitzvah, he attempted to have penetrative intercourse with his wife. And the key word here is on attempting. Even if he didn't finish completely, but he got a slight penetration, and again, different rabbis rule exactly what that means, how much, everything from just a touching of the genital areas to each other to something more than that. And afterwards, after they attempted this, this is when the kala became nida, and this is exactly the case of the woman who comes to Rivki that they've attempted for a few days. Rav Ovadia Yosef says, mutarim biyuchud, they are permitted to be together alone. As the Ramah, the first opinion he brought in, that they don't need any kind of supervision, this is how Rav Ovadia Yosef is ruling. And he says it's because they did make this attempt, and so therefore his urge, his Yoetzet, isn't going to overcome him because they did make an attempt, and V'hi atida lehi taher, she will in the future become tahora again, and he has bread in his basket, pat b'tasalo, so he knows he's going to have another opportunity, and therefore mutarin lishon b'cheder echad, they are permitted to sleep in the same room without any shmirah, without any supervision. So that's my next slide, sorry. So that is the halacha today for this case, that of this couple that comes to either the PT or the Yoetzet first, that they can't consummate the marriage, that it is enough if they attempted, that they don't have to observe these laws of yichud, and they can be alone together in their new marriage home. And that is the psak that most rabbis accept. I just want to point out that these types of psak are very individualized for each couple, and it's very important to find a rabbi or a yoetzet that the couple feels comfortable discussing these types of intimate matters.
Thank you so much, Stacy. So let's say that this bride is like, it is painful, right? So when she answers the question, is this painful? And she says, yes, it's actually very painful when we're attempting intercourse. And she gets the proper referral because she came to the Health and Halacha day, and she heard about pelvic health physical therapy, and she heard that sex should not be painful and that she should get help ASAP. So, and now she's working with a pelvic health PT to have pain-free intercourse. People ask me all the time, before we get to the halachic issue, people ask me all the time, what does pelvic health, what does it look like? What can I expect is going on? So the most important thing to know about pelvic health PT is that it should not hurt. And so it's very important for women when they're in treatment that they, a lot of women are like grin and bear it kind of girls. And they're just like, no, it's fine. You just do what you need to do. It's fine, that it shouldn't hurt. And that if they are having pain, that they, during treatment or during their home exercises, that they need to be communicating that with their therapist and let them know. And in my office, I always tell patients on a scale of 1 to 10, 10 being the worst pain in the world, 0 being no pain, you're okay with being somewhere between a 4 and a 5. And all the dentists out there will forgive me, but I say 4 or 5 is like when you're at the dentist and they have both hands in your mouth and there's no tools involved, just both hands in your mouth, and like it's super uncomfortable. Like it's annoying, they're like, oh, where'd you get your shoes from? Those are so cute. And you're like, rah, rah, rah. Like that's annoying. Okay. That's about how the level that I'll allow patients to get to in therapy. It should never be more than just a little bit annoying. So you need to communicate that. So how do PTs get involved in this field anyways? So physical therapists are specialists in muscles and nerves. And as Riva described so beautifully before, the pelvis is full of them. And these muscles and nerves may not be, maybe firing in ways that are painful in response to touch or response to something going inside. And we want to kind of discern what is it about what's going on with this woman's body that's causing this to become painful. And for each person that may be different, we want to discover if there are any sensory issues or underlying orthopedic issues, or maybe scars from previous surgeries. And for many women, I'm just going to show a different kind of model. But if this is a woman's vulva, if this is the labia majora, just to orient you where the hair grows, this is the clitoris at the top, and this is the rectum at the bottom. This area at the bottom, at the introitus, this area here is usually the area that most women will tell me they're having pain. It's usually this area. So oftentimes our treatment will focus on the muscles that lie in the skin and the nerves that lie underneath this area to kind of help normalize sensation and decrease pain, like Riva described, working with dilators and pretty purple, non-threatening colors, working to kind of help allow something into this area without it triggering a cascade of pain and discomfort, and improving their muscle awareness. And, oftentimes when things are painful, our muscles tighten up in anticipation, which is why we really want this woman to stop having any attempts at intercourse until she gets the proper treatment. And good physical therapy, good pelvic floor physical therapy is really a wonderful partnership between the patient and the therapist, really working together to help this woman get to where she would like to get to with her goals for what she'd like for herself. And most important thing to know is that this can get better. Women oftentimes are very distraught and despair that this isn't supposed to happen to me and it's never going to get better. And it's really important to know that there's treatment out there and people do get better, God willing, and really to get the help. So this brings us to the next question. If they're not supposed to be having intercourse during treatment, because we don't want her to keep having this pain with attempts, because this just makes those muscles become more and more sensitive and more guarding, and closing down, like anticipation of pain, like as if you put a pen into someone's eye, like your whole face, your whole mouth, all your muscles tighten. So oftentimes they're instructed not to have intercourse. But oftentimes these patients are very concerned that when they're being intimate with their husband in other ways during this time, during treatment, they're concerned that there's going to be an issue of shechva zera, of ejaculate not hitting because it's not able to enter the vulva or the vagina because of pain. They're concerned about wasting of semen. when in a halakhically observant couple. So question to Yoetzet Stacy is, what is this couple halakhically supposed to do if they're not able to have penetration because it's so painful and she's undergoing treatment until they're ready, until she's ready to have intercourse and her body is ready to be able to have a penetration that's not painful? What can they do? And what do we do about this issue with this concern about Shechvat Zera?
Okay, thank you, Rivki. So the first halachic matter we talked about was, could they be in yichud if they hadn't consummated it? And you're right, the second halachic matter, if this becomes a long-term issue, is the idea of hashkavat shechvat zera, or spilling seed. Again, with proper rabbinical yoetzet advice, working with the PT or sex therapist, the couple can find halachically permissible ways specific to their situation to get through this adjustment period. While spilling seed is a very serious halachic matter, it's important to understand that intimacy in marriage has two separate components. First is the mitzvah to be fruitful and multiply, pru'urvu, but there's also the mitzvah of ona, which I'm going to talk about in the last case, the husband's obligation to please his wife. Sometimes these two mitzvot work hand in hand, but at other times, such as this situation, they may be in conflict, and the posek must take shalom bayit into consideration when dealing with this type of scenario and issuing a psak. So this will be very case specific to each couple, so I'm not going to give any specific examples here, but everybody should be aware that rabbis and yoetzot are very sensitive to this topic, and there will always be a way to work it out that this couple can find satisfaction while undergoing their treatment.
Thank you so much, Stacy.
All right, thank you so much for that wonderful case number 2. We're going to move on to case number 3 now. And we've touched upon until now overactivity and discussions about tightness and pain within the pelvic floor. Our next case is going to deal with underactivity and weakness within the pelvic floor. Now, as I mentioned earlier, one of the primary functions of the pelvic floor muscles is to help with supporting the 3 organs of the pelvic floor. These organs are primarily suspended up and aligned in our body against gravity by ligaments that connect to the lumbar spine, to the low back. However, there are many things that can interfere with the integrity of the ligaments that connect these organs and keep them up aligned against gravity. And there are certain risk factors that can contribute to them getting weaker or laxer over time. For example, with every pregnancy, labor, and delivery, the ligaments can get laxer and weaker. In addition, if a person has a history of chronic constipation and straining and bearing down while they're trying to pass a bowel movement, that can push a downward pressure on the organs, create a downward force, and that can make it difficult for the ligaments to keep the organs up and aligned against gravity. In addition, with postmenopausal hormone-related changes, the ligaments can get laxer and weaker. And finally, people who have jobs that involve a lot of heavy lifting, such as flight attendants, or for example, if a person engages in types of exercise that involve very heavy weighted lifting and like squatting and lifting, such as, not to bash any form of exercise in particular, but as a pelvic floor PT, I take issue with ProFit as a form of exercise for that reason, because I just think about, oh my gosh, your poor organs, what are you doing to them? So those types of things can create and lead to cumulative downward pressure on the organs. And should the ligaments have too hard of a time keeping those organs up and aligned against gravity on their own, having a strong pelvic floor is a great backup plan. Think of it as like a wonderful plan B, that by strengthening your pelvic floor muscles from below, it can help account for the weakness and laxity that's existing above within the ligaments. And when it comes to strengthening the pelvic floor muscles, especially in a case where there's descent of the organs, which is referred to as pelvic organ prolapse, we want to help strengthen the pelvic floor muscles in a position where gravity is not working against us the way it is all day, every day when we're walking, standing, moving around, and the gravity is working downward on our organs. So I joke around with my patients that ideally the best position for you to do your pelvic floor strengthening exercises or up training Kegel exercises would be while doing a headstand or a handstand, because then gravity is working in your favor to bring the organs back into the body. but that's not very practical for most people. So the next best thing would be to purchase either like a wedge or to position oneself on pillows in a position where the hips are elevated, almost in a bridging position, because in that position as well, gravity works in one's favor to pull the organs back into a better alignment and improve alignment within the body. And then performing the strengthening exercises with the organs in improved position allows for a better outcome and for helping to restore an improved pelvic organ alignment. So while pelvic floor PTs love to be able to fix everything and to help everything get back up into place as it should be, it not always is alone and sufficient to do the trick when it comes to prolapse. And sometimes when there's organ descent or organ prolapse, there may be additional help required. And I like to explain to my patients that the progression of treatment with prolapse is first we want to do the most conservative form of treatment and then work our way up to things that are a bit more invasive. So the most conservative form of treatment is pelvic floor physical therapy. Then the next level would be using a pessary, which is a silicone device that can be inserted. And I'm just going to pull up a slide to show you what some pessaries look like. I know that some of them look really scary, but they're not always that way. And there are definitely many options, so you can speak to your gynecologist to find the one that's best for you if it's needed. But that's the next level of invasiveness, and it is inserted vaginally, and it helps to support the organs from below, adding some additional support should the muscles not be strong enough to provide that support. And last but not least, the most invasive type of treatment for prolapse, which is what we pelvic floor therapists look at as a kind of like a last-ditch effort, would be surgery, because the outcomes are not always great, and surgery, we always kind of want to avoid it if we can, but when necessary, there are times where it is warranted. But definitely trying to encourage patients to participate in more conservative, less invasive approaches rather than or before trying something more invasive. Now, when it comes to the pessaries, these are the kind of thing that you don't just like order it off of Amazon and like DIY it. This is the kind of thing where you want to go to a specialist. You want them to fit it for you because as you see, there are many different options. And if it doesn't fit just right, then it could feel really uncomfortable or painful, or if it's too small, it might even fall out. So you want to make sure that you're getting it fit by a specialist who knows what they're doing. And pessaries also range in the frequency of usage. Some are designed to be inserted and to then remain internally until the next doctor visit, let's say 3 months later, where they remove it, clean it, and then reinsert it, versus others are designed to be used as needed by the patient when they choose to, as needed. So for example, if a person knows that they tend to notice their prolapse symptoms worsening when they're taking a step class or doing an aerobics class or jogging, so they may only want to insert the pessary for that activity where there's increased intra-abdominal pressure, which puts downward pressure on the organs and would tend to promote prolapsing. So kind of just providing a little extra support during activity where the organs are going to tend to descend. This way you can help keep them up and aligned against gravity and then remove the pessary afterwards. So my question to you, Yoetzet Rebbetzin Racheli Tavis, is what do pessaries qualify as with regards to chatzitzas? Must a woman remove a pessary for mikvah? Love to hear your thoughts on that, please.
Okay, thank you for asking those questions and for giving such a good explanation of the purpose of them and the importance of them when it's needed. So before I jump to answering your question, something that I do want to say that I touched upon on the previous case that we talked about on the topic of damaka, that this actually can also, in theory, so that's why I wanted to mention it, that it can also apply to a pessary, that inserting or removing a pessary may, right, hopefully it's inserted properly, so it's not often the case, but in a situation where insertion or removal of the pessary would cause a wound and would cause an injury to a woman's vaginal canal or certain parts of the genital area. So that would constitute as damaka, and therefore bleeding from that procedure wouldn't render a woman a nida. So now, as you ask, the bigger question that comes up with pessaries is, what about going to the mikvah with a pessary? Is it a chatzitza? Is it a barrier? Now, immersion in the mikvah requires a full body immersion all at once. We're, according to the Ramah, and that's what's underlined, all barriers preventing the flesh and the waters from meeting have to be removed, that the waters and your flesh must meet, and there can't be any barrier or anything preventing the water from reaching and touching all parts of your skin and all parts of your body. Now, there are 3 parts to our body when it comes to this area of mikvah. So the first is what's referred to as nigla, revealed, but you can see. That's like the epidermis. And that part of your body, on a halachic level, must be clean and water must reach it. So you have to wash your hands and your face and between your fingers, right? You have to remove all dirt. And not only do you have to clean it, but the water actually has to touch, right? It has to touch the palms of your hands. You can't make your hand into a fist because then the water hasn't reached this, what's the nigla, the revealed part of your hand. The second level is what's called the beis hastarim, the hidden parts of our body, where these are parts of our body that on a halachic level need to be cleaned, but water doesn't actually have to reach that area. So one example of that is the inside of our mouth. You must brush your teeth and floss your teeth before you go to mikvah, but you don't actually have to open your mouth underwater. Right? Your mouth, your teeth just have to be cleaned in preparation for mikvah, but the water doesn't actually have to touch your teeth. Same thing with your eyes. You have to make sure that you remove all eye makeup, which may be part of the nigla, the external part of your body. But if you have lenses, the lenses have to come out, but you don't have to open up your eyes underwater. And lastly is what's the third level, what's makom balua, what's like swallowed up inside, so to speak, in our body. And those areas do not have to be cleaned, and water does not have to reach that area. So an area like that would be if there's an IUD, which is a form of contraception that is an intrauterine device, right? By definition, it's in your uterus. So that area doesn't have to be cleaned. That IUD does not have to be removed for mikvah, or a heart pacemaker. Right? Also something that's completely internal and swallowed up, so to speak, in your body, doesn't have to be cleaned, and the water doesn't have to reach there. So now the question is, what category does the pessary fall into? So as Dr. Prel so well explains, especially with the graphics, is that the pessary is placed in the vagina. And so therefore it actually falls into that middle category, into that beis hastarim. And so therefore it should be removed for mikvah. And it probably also should be removed for your hefsek and some bedikut as well. And actually this is probably similar to a case of a woman who uses a NuvaRing as a form of contraception, where the NuvaRing is a hormonal contraception ring. Like imagine, and actually is one of the similar images to the pessary, so it looks like a rubber band type of thing. And it is inserted vaginally, and it has localized hormones that are released locally as a form of contraception. And so a woman who uses the NuvaRing as her form of birth control should ideally remove the NuvaRing when she's doing her hefsek tahara, day 1 bedika, day 7 bedika, and the mikvah immersion. So now going back to the case of a woman who has a pessary, if it is hard or impossible for a woman to remove the pessary herself, or if it's placed in the cervix, then she should consult with her rabbi or Yoetzet if it in fact does have to be removed. But because most pessaries are subcervical, so it's in the vagina, it means it really, ideally, should be removed for mikvah. Now, I will lastly just add in closing that in a b'diavad situation where a woman immersed with the pessary still inside, she should ask a shayla if she needs to remove it and if it's required for her to immerse again. And I think we're ready for case 3. Yoetzet Stacy.
Okay. So our next case is again following along on this pattern of the weaker pelvic floor area. So this is a question that is a conglomeration of different women's experiences that I may have spoken to, not a particular woman. So a woman in her late 40s calls me on the phone. She is nearing the end of her Shiva Nikiyim, her 7 days, and approaching mikveh night. Earlier in her marriage, she used to look forward to going to the mikveh, but it has become a source of dread. There is just no more excitement in this aspect of her marriage. She feels like she is performing a duty for her husband, and she gets little to no satisfaction. She feels the years of pregnancy and childbirth have taken their toll on her body, and she barely feels any sensation during intercourse. Is this aspect of her life hopeless? Is she doomed to a marriage devoid of sexual satisfaction? Several things come to my mind as I ponder an appropriate answer to her question. I recognize, first of all, that this issue will not be solved by me alone. This will definitely require a referral to a pelvic floor specialist. I will try to answer in a multifaceted way. First, I want to clarify if this is a more holistic issue, which I suspect it is. I ask her if she also might be experiencing incontinence. While she is surprised at this follow-up question, she answers in the affirmative. I explained to her that these two issues are intimately, pardon the pun, connected, and that an amazing physical therapist specializing in the pelvic floor can help solve both of these issues. But before I send her off to the specialist referral, I want to take the time to address what she said about, quote, performing a duty for her husband and the role of physical intimacy in a Jewish marriage. A side benefit of observing the laws of Taharat Mishpacha is that sometimes it can serve as a barometer for the relationship. If several cycles go by without excitement or desire, then it might be time to reflect on the state of the union and if the couple needs a psychological or medical intervention. While it is always nice to be sensitive to our husband's needs in a marriage, Halacha actually views the obligation to be on the husband to make sure his wife is experiencing sexual satisfaction. This mitzvah is independent from the mitzvah of procreation, as it continues to exist through all stages of a Jewish marriage, whether it's during fertile times or if she's actually pregnant, in which case she's not going to get pregnant again, nursing, or postmenopausal. And this mitzvah is called Ona. And I'm going to show you some of these sources. So the first is from the Chumash, Parshat Mishpatim, Shmot, Perek Kaf Aleph. It's in the context of a slave who is put into slavery with the intention of her becoming the wife, and the laws of her now husband and whether he can take an additional wife. So the halacha is that if he does take an additional wife, he shall not diminish she'ira, ksuta, ve'onata, lo yira. So these three things that are translated here according to Chabad.org, according to the Rashi: sustenance, food, clothing, or her marital relations. And if he does not do these three things for her, she becomes a free woman. There's no money. She doesn't have to repay any debts or the debts of her father. So that's the origination of a husband's marital duties. Rashi there, as we saw in the translation on Chabad.org, translates these three things. As she'ira is mizonot, food, ksuta is, as it sounds, her clothing, and onata, that refers to sexual intimacy. The Ramban, however, has an interesting interpretation where he says that all three of those terms in the pasuk refer to a different aspect of sexual intimacy. For the sake of time, I'm just going to read it in English. Such is the style of the Torah, always to mention sexual intercourse in clean and brief language. Therefore, it mentions these duties by means of allusion, she'ira, ksuta, and ona. And in this very lengthy explanation, he describes how each one refers to sexual intimacy, referring to the three things which are usual when a man comes together with his wife. Thus, the verse is properly explained in accordance with the accepted law, while the sustenance, the food, alimentation, and the provision of her raiment, so her clothing, is according to the Ramban, derabanan. It's a rabbinic law, not Rashi had it as a doraita stemming from the Torah. So I wanted to conclude with these laws. Another Ramban in the beginning of Bereshit, where it says that the man and the wife will become like one flesh, basar echad. Rashi there says what's represented by the basar echad, one flesh, it's the child that they would have together. The Ramban argues, and he says, no, this can't be the uniquely human, intimate experience of becoming like one flesh, because animals also have children, and it's not unique to human beings. So he says, the correct interpretation appears to me that in cattle and beasts, the males have no attachment to their females. Rather, the male mates with any female he finds, and then they go their separate ways. It is for this reason that Scripture states that because the female of man was born of his bones and flesh of his flesh, bone of his bone, flesh of his flesh, he therefore cleaves to her, and she nestles in his bosom as his own flesh, and he desires to be with her always. And just as it was with Adam, so was his nature transmitted to his offspring. It's saying it's genetic that men and women, husband and wife, should want to cleave to each other, to be together, leaving their fathers and their mothers, and considering their wives as if they are one flesh with them. So that is the Jewish view on marriage and sexual intimacy within marriage. That is very important. It's something to definitely be concerned about if it's no longer what it used to be, and that the husband has a special obligation to his wife, and the wife has to do what she can to ensure that her husband is able to fulfill this obligation. Okay, and Rivki can give us a pelvic floor therapist perspective on this now.
Right, so thank you so much, Stacy. That was such a beautiful explanation of mitzvah ona. So if this woman, was referred to my office with complaints of, difficulty with sexual appreciation, difficulty with orgasm, so, and as Stacy pointed out, very astutely, that the first thing we'll always ask is about the other systems that are involved, because what we know is that if we're again looking at this pelvis, so this is a person facing towards you. These are their hip bones. This is their spine in the back, and the front of the pelvic floor, the pubic bone in the front. So if we're looking downward into that person, into this bowl, which is all those muscles that are supporting, and I call this a Yoetzet view, because I'm just put it towards the camera, because you could see the nekavim, right? You see the rectal opening. We could see the vaginal opening here. And the urethra, which is the hole for urine, if you can see so up, those are the holes, right? And all of this red stuff, as Riva pointed out, are all the muscles that support all those holes and all the organs that are attached and hooked up to the hole, like the bladder, the vaginal vault, and the rectum. And all of these muscles and the nerves that run through them are responsible. And there's a lot of overlap between urinary function, bowel function, and sexual function. So when there's a disruption in one of those systems, it could be indicative of some difficulty with the interworkings of this very complex musculoskeletal system. So we want to be able to look at them holistically and take a look at, what is going on with this woman and what is the driver? Why is she having difficulty? Assuming that she had normal sexual function at some point in her life, what has changed? So there are a few, risk factors of what could be disrupting it. We know that childbirth is one of the number one reasons for pelvic floor dysfunction, whether it's a pregnancy, whether it's a vaginal delivery or a C-section, whether she's had some kind of surgery, or has some kind of scar tissue. And all of these kinds of issues can interplay and impact these muscles and nerves that are responsible for sexual function. And what happens oftentimes is that while these injuries might have happened 20 years ago, with the pregnancy 15, 20 years ago, their body compensated well for it. And as the body ages and as there are hormonal changes that start to happen in the perimenopausal and menopausal time, those tissues, our resources start to deplete, and our ability to compensate for things that our body is able to compensate for when the tissue was younger and stronger, you start to kind of feel the fault line starting to happen. And sometimes I'll have, 70-year-old women come into my office, and I'll tell them whatever difficulties that they're coming to me for. I said, well, actually, this is really a postpartum issue. Like, you're actually just postpartum. These are, and they laugh at me because their last pregnancy was 50 years ago. But what happens is sometimes these issues start to come out later in life, and they really require intervention. So what's really important to know is that women do not have to live this way, that there's so much that can be done from a pelvic floor perspective. If we're looking at it purely from a muscular neuromuscular perspective, we're looking at the sensory issues that might be involved, the nerve damage, Muscle weakness certainly can contribute when muscles have been stretched out by, let's say, hey, pushing an 8-pound baby through the vaginal vault more than once or even once can cause damage to those muscles and their attachments and nerves. Difficulty with muscle in coordination and the ability of those muscles to contract to create stability for those nerves and for those organs to be able to feel the sensation of intercourse or foreplay. And all of this can impact sexual appreciation. So, in terms of physical therapy treatment, we want, that might, depending on what the reason for this woman's difficulty is from, it may become strength. There might be strengthening or coordination training, perhaps biofeedback, which is helping a person reconnect with their muscles and increase their awareness of their muscles tightening and relaxing, addressing postural issues. There are many, many tools at our disposal as pelvic health physical therapists to really help this woman regain strength and control of those nerves and muscles that are responsible for her sexual appreciation and help her attain her goals. It's also important to know that this is a multidisciplinary approach as Stacey mentioned before, may really be very important. We want to make sure that she's referred to the proper physician to make sure there's no medical issues that need to be addressed beyond the scope of physical therapy, whether there are hormonal issues at play, or other underlying medical conditions that could be, or pharmaceutical issues that may need to be regulated to help her reach orgasm or arousal and maybe interfering with that process for her. In addition to addressing the physiological changes and challenges, the emotional components cannot be neglected. We want to make the proper referrals to perhaps a couples therapist or an individual therapist or a sex therapist or all of the above to help work on any underlying emotional issues which may be interfering with this couple's ability for her to attain arousal and orgasm and improve her sexual appreciation during intercourse and during all kinds of sexual activity that are just not bringing her pleasure anymore. So it's really important that we have this kind of holistic team approach to help this woman. And it's important for women to feel empowered and not feel like this is just their fate. This is just what happens when you get old. Your organs start falling out and you start leaking urine and you don't like sex anymore. That really, if anybody is struggling with these issues, know that there's help out there. Know that we don't have to just live this way, that we can improve our lives in all these different areas. And the most important thing is reaching out and speaking to Yoetzet Halacha or a medical provider or her pelvic health PT, because that's really could be the beginning of really helping to improve and empower women to improve their lives.
Thank you so much, Rivki. We're going to conclude with our contact info. I just want to say how amazing this was for me to work with Rivki and Riva. And I hope everyone here learned as much as I did through their amazing presentations, and how wonderful it was for me to unite with my beloved Chavrusa Racheli and to work together once again. So here is all of our contact information, Dr. Riva Prell, and you can see her phone number and her email. And Yoetzet Halacha /Rebbetzin Racheli Taubes, and here's her information. And Rivki Chudnoff, you can see her information here. And this is me, Yoetzet Halacha, Stacey Goldman, with my phone number and email. And these you can, if you didn't get a chance to catch all this, I think our slides might be available, or you can Google any of our names and we're easily findable. And finally, we're so proud of Dr. Riva Prell and her book, which you can find on Amazon, The Inside Story, The Jewish Woman's Guide to Lifelong Pelvic Health. I know it's on my bookshelf, and I encourage everyone to invest in this amazing book. Thank you so much.
Thank you.
Good night.
Good
Thank
night.
you.